and welcome to another episode of the JASN podcast. I'm Kurella Tamura, a deputy editor of clinical science at JASN and a professor of medicine at Stanford University. Well, August 2025 marks the 20-year anniversary of Hurricane Katrina, the worst natural disaster in U.S. history. As many of our U.S. listeners know, Katrina forced the closure of nearly 100 dialysis facilities in the Gulf Coast region, leading to the displacement of thousands of dialysis patients. So I think it's the appointed time for us to reflect on the lessons we've learned around disaster management and disaster preparedness. And to help us explore this topic, we have an excellent group of authors who are first authors of a paper coming out in JASN entitled A Roadmap for Disaster Risk Reduction and Management in Kidney Care, a scoping review and content analysis. So please join me in welcoming Dr. Shaifali Sandal and Saly Wazze. Welcome, and could I ask you to both introduce yourselves for our listeners?
Thank you very much. I am Shaifali. I'm a transplant nephrologist at McGill in Montreal, Canada. Although I did most of my training, including my nephrology fellowship in the US. I am a mid-career investigator, but I recently only transitioned to a clinician scientist track. Actually, I'd say recent, it's been 5 years now. But my research program or research lab, we call it BEST Care. So building equitable, sustainable, and stronger health systems in kidney care and transplantation. And the focus of my research is to strengthen health systems that deliver care to the patients that I provide care to. And arc of inquiry that I focus on entails climate change mitigation and adaptation related efforts. My program, the core belief in my program is interdisciplinary and multidisciplinary approaches. And I learned it from someone. I call myself a talent hunter. I bring some of the brightest minds from non-medical fields to sort of come up with approaches that can then be applied to medical fields. And one such bright mind is Saly. So I'll let her introduce herself.
Thank you, Dr. Sandal. And thank you, Manjula, for having us. I am Saly. My background is in sociology, and I'm a research assistant, part of Dr. Sandal's research lab. I work on the qualitative analysis aspect of our different projects, and as a sociologist, I'm interested in nephrology as a field where there are many intersections between the health system and a highly vulnerable patient population.
Welcome to you both. And Shafali, I loved that introduction. I mean, there are so many areas in nephrology where multidisciplinary care is really important. This is one perhaps where we don't think about it often, but truly it requires so many different backgrounds and expertise to address it well. So maybe that's a segue into leading into my first question for both of you. What types of challenges do disasters present for providing dialysis and kidney care? At the outset, I mentioned Hurricane Katrina, but as the last few years have shown us, disasters are more than just, weather-related disasters. They're all types, aren't there?
Absolutely. So when I became interested in this subject, I'll start by what motivated me to pursue this. I work in Montreal, and we provide care to a lot of people who live in our remote communities via our satellite dialysis units. And in 2023, there were massive wildfires in Canada. I'm sure many of our listeners are aware, as the wildfires, the smoke actually sort of, I don't know what the right word is, but migrated to many parts of the US, and the sky was orange at one point, and air quality was one of the worst ever seen. At least in places I live, but I read that in the tri-state area as well. So during that time, our program was impacted. And without going into the details, that's exactly what motivated me, because I think somewhere we realized that after that event, how susceptible we are to disasters. And even though we had a sort of a protocol to care for patients during a disaster, there were a lot of deficiencies. And that's what motivated me to do this. So one of the first things I looked up is, there's a wealth of knowledge, and there's a whole Office of Disaster Risk Reduction from the United Nations. So I actually am very inspired by the work that comes out of that office. I'll start by saying what they say is a disaster and how that is different from an emergency, because there are some preparedness protocols across Canada, but they call it an emergency management, not disaster per se. So the United Nations says a disaster is a serious disruption of the functioning of a community or a society at any scale due to a hazardous event, but that interacts with exposure, vulnerability, and capacity, and that leads to one or more of the following: human, material, economic, environmental losses, and impacts. It's different from an emergency, whereby the disruption of the functioning of a community or society does not occur. But what's very interesting about this definition is the interaction of exposure, vulnerability, and capacity, because that sort of tells us that an emergency in one setting could be a disaster in another setting because of the capacity of the health system at baseline. Then coming to what the hazardous event can be, as you very rightfully pointed out, it can be natural. So it can be a climate-related and unrelated event. So hurricanes, earthquakes, so climate change related and climate change unrelated event. But it can also be technological. Our society is so dependent on electricity, and everything is electronic nowadays, that one power outage and it's almost presenting itself as an emergency, maybe a disaster setting. And it can be societal and human cause, which is what we have learned in the past few years, such as like the conflicts, wars, terrorist attacks, etc. So the scope of disaster and emergency management is definitely expanding globally. And as a Canadian, I realized that a few years ago, and that was my motivation to take on this field of inquiry. And dialysis is special. Why is it special? Because it's one of the rare life-sustaining therapy that's offered on such a large scale in an outpatient setting. I've given a talk a couple of times, and I challenge my audience to tell me one life-sustaining therapy that's offered on such a large scale as an outpatient. Because people talk about artificial hearts, etc., but very few people get that. Like hundreds of thousands of people are getting dialysis in North America as an outpatient basis. And the best answer somebody came up with was an oxygen cylinder. So I was like, okay, fine, I'll give you that. But anyways, dialysis is a special therapy. So that's why we need a robust disaster and emergency management protocol, because the provision of dialysis requires medical equipment, it requires electricity, it requires clean water, it requires consumables, medications, and trained personnel, which could be the caregiver of a person on home dialysis or a nurse or a technician. And all of that can be disrupted during a disaster setting. Kidney transplant recipients are not immune as well, because the graft survival and patient survival as well depends on an uninterrupted supply of immunosuppressive medication, as well as a clean environment. I have taken care of patients who were displaced by the Syrian war and lost their transplant because they did not have access to their medications. So all our patients are susceptible to disasters, and that was my motivation to do this work, because the recognition of the vulnerability of our patients can sometimes be missed by emergency organizations. And in certain disasters, such as earthquakes, acute kidney injury can present itself on a mass scale, which can very rapidly overwhelm the system's capacity to deliver care to not just the new patients, but existing patients. And lack of preparedness and poorly organized efforts can have disastrous consequences. And that's why I think these are the challenges I think that disasters presents for kidney and dialysis care, and the motivation, my motivation to pursue this work.
I mean, thanks for that. That's giving us a lot of information to chew on. And I don't think I had really understood the idea of disasters as in the interaction of the environment with a vulnerable population until your explanation. So that's really, really insightful. Maybe if I could ask both of you, what efforts have been undertaken, either in North America or internationally to coordinate disaster management for our patient populations?
Well, on the national level in Canada specifically, efforts have varied by province. So, for example, in British Columbia, they have hemodialysis emergency nurses, and these are nurses dedicated to disaster support and education at their respective kidney units. In other provinces, like in Ontario, they have a renal network that focuses on providing both financial support and emergency directives to all the units participating within that network. And then in other provinces, or other units in other provinces, have more on-the-go responses. And as all of these units remain dedicated to patient and staff safety, and as we have mentioned just now, with the increasing occurrences of disasters, and actually, as we speak right now, there are ongoing wildfires in Manitoba and Saskatchewan that are forcing many patients to evacuate. And so the need for a more systematic approach to disaster management in kidney care units has arose. If we talk about the US, post-Hurricane Katrina in 2005, as we approached the memory of that, the CMS established the Kidney Community Emergency Response Coalition, and they have mandated that all Medicare certified dialysis facilities, including for home programs, need to maintain a comprehensive emergency and disaster management plans. Whereas talking on the international level, for example, organizations such as the International Society of Nephrology, or ISN, and also the European Renal Association, they have both formed their own renal disaster relief task forces. And so these initiatives have played a key role globally in coordinating international relief and providing emergency dialysis care during both natural and human-made disasters. There could possibly be other initiatives out there that we're not aware of, but in Canada, that's where we don't have that kind of initiative, and that's where the core aspect of our work is aimed at.
Thank you. That's like such great context. Maybe let's transition to talk about your study. So, what question were you trying to answer, and how did you design the study with that in mind?
So I'll tackle that on because so when this happened to our program in 2023, we sort of we were like, you know what, we need to have some kind of an outline. Like this is where you start, and this is what you need to do. But where do we get that outline from? So we actually looked at the literature, like maybe somebody has done this, and there were a couple of frameworks, but I personally found them very abstract. I found them not pragmatic. Like where do you start from? And maybe they were very applicable to wherever they were coming from, but we didn't find a framework that that I could use in my program and then adapt it to my program. And that is what we wanted to do. So our goal was that we were going to, and there's a lot of literature, and there's very little empirical literature, but there's a lot of opinion pieces, reviews, editorials, which are like not really like evidence oriented or but they're lived experiences and they're very valuable. That's where I took the feedback from some of my qualitative colleagues as well as the people who are in my research lab. And we wanted to synthesize the literature, but we decided to do only contemporary literature and not go back all the way 50 years and or since inception. And we said like we came up with a bunch of articles even when we focused on the last 10 years. And once we got that literature, we said, why don't we synthesize it? Why don't we sit down, read every single line that is being said by in this paper, and why don't we come up with a way to synthesize that literature? And Sally will go over how we did it, but it was just like a bunch of coding, and then one day I just sat down and was like sitting and on my screen and looking at all the codes that Sally and I generated. I'm like, let's come up with now a good mnemonic, and that's how we came up with the mnemonic. Well, I'll talk about it. I'll let Sally discuss the exact approach we took.
Yeah, thanks,
Thank you.
Shaifali. I imagine many of our readers are familiar with the concept of a systematic review, but there are probably more who are not familiar with the idea of a scoping review. So, Sally, would you tell us a little bit more about, that and, the methods that you used in this study?
Definitely. So, a scoping review and a systematic review differ in several key ways. A scoping review aims to explore the extent of a particular topic, whereas it looks at taking count of the key concepts, the types of existing evidence, and identifying any gaps in the literature. And so, kind of the guiding principle here is that there is a broad research question, such as what is known about topic X? And so this includes a wide range of studies and study types, including gray literature. In contrast, a systematic review focuses on answering a specific, narrowly defined research question. And so, while systematic reviews typically aim to synthesize findings, sometimes through meta-analysis, scoping reviews provide a descriptive overview without necessarily evaluating the quality of the included studies. And so, in our case, when it came to the analysis, we used a content analysis approach using the framework method. And so, to explain that a bit more, as it's typically used in qualitative and textual analysis. This works by identifying patterns, themes, or meanings within the data. And it involves several steps. It is very systematic, but most importantly for our work, this included a careful review of article contents, preliminary coding based on our research aims. And so this helped us inductively develop a working analytical framework. And then as we went through more and more of the articles, we applied this framework to the data and updated it as we went along. And then the result was an Excel matrix published in our paper with all of the developed categories and ideas. And in the end, this is what helped us develop a roadmap synthesizing the lessons learned and the best recommended practices in the literature when it came to disaster management in kidney care. And that is kind of also what our main question aims to answer.
Thanks, Sally. Before we get to the roadmap, could you just tell us a little bit more about the types of settings or disasters that were included in your review?
Yeah, so very briefly in our review, our understanding of disasters included both natural and human-caused disasters. And some examples included were, when it comes to natural ones, included hurricane, earthquake, flood, typhoon, tsunami, torrential downpour, and others were more man-made, including war, economic crisis, and CBRNE. Now, we made special considerations when it came to COVID-19, as it was a prolonged disaster that doesn't necessarily impact access to resources or coordination channels in the same way that other mentioned disasters do. As for the countries covered, we included US, Asia Pacific, Ukraine, Turkey, Syria, among other countries, but many of our articles featured a combination of different countries and a combination of different disaster types together.
Thanks, Sally. So, your literature synthesis led to the development of a disaster risk reduction and management roadmap that you both alluded to. For our listeners, can you describe for them the elements of the roadmap?
While I describe that, I just want to tell you that how we did it, because it was actually ended up being very overwhelming, but the end product was very exciting for the both of us and the entire team involved. Because so the way content analysis works is that, Sally and I independently would read a paragraph, a line, and we'll be like, this is what they're saying, this is what they're saying. So here they're talking about contingency planning, here they're talking about how to handle surge capacity. So we came up with these like codes that define different, like that each study was saying, this is what you should be doing, this is what we did, this is what we recommend should be done around, because this is what we experienced. So once we created those codes, we had them out in this huge sheet, and I had it on paper, I had it on my screen. How do we organize it? So first we used a deductive approach. So deductive means that we had a framework on how we want to organize our framework. So we decided to use again what the WHO and United Nations recommend. And when it comes to disaster management, they have four big themes: mitigation, preparedness, response, and recovery. We decided not to look at mitigation because then the research question is becoming even more broad. So we focused on preparedness. Preparedness means establishing a plan to enable timely, effective, and appropriate responses to a potential or emerging disaster and enable a smooth recovery. Response means the actions that are taken directly before, during, or immediately after a disaster. Recovery entails returning to normal activity with an approach that avoids or reduces future disaster risk. So once we had that deductive sort of three big branches under which we wanted to put our codes, then we sorted out our little codes under each category, and we were able to come up with this nice mnemonic. So for preparedness, we came up with the ABCs of preparedness. So what are the ABCs of preparedness? And it flew really well. And I think it was one of my, I said, Sally, this is my eureka moment. My God, why hasn't everybody thought of this before? So what are the ABCs of preparedness? So A is assess needs, risks, and vulnerabilities. The risks and vulnerabilities of one region may be different than the other. Canada, for instance, is at risk of wildfires. And in the foreseeable future, I don't see a war happening. It could happen, but I don't see it happening. Whereas another country, which is in the conflict zone, may, in that setting, a war might be one of the biggest challenges that a particular region might be facing. So they may want to prepare for a war, and that preparation entails a completely different approach than the preparation for a wildfire. So a disaster management preparedness protocol first needs to assess what is the region and the program at risk for. So that's the A. The second is build a task force. We cannot exist in isolation. And that is something that I think everybody in the field of medicine understands. The provision of dialysis depends on so many services, transportation, pharmaceutical, delivery of medications, supply chain, you name it. I feel like almost every industry is somehow involved delivering directly or indirectly delivering care to a patient on dialysis. So it requires understanding the scope, and then you build a task force depending on so you build a task force depending on how much the risks that you have identified. So in Canada, for instance, we thought building a national task force would be more reasonable, whereas in some European regions, perhaps a like multi-country task force might be something that would be more necessary. And again, that depends on the region, and it's very context specific. And then the C's are capacity building, goes without saying. Once you identify your risks and vulnerabilities, you're able to create the right resources, monetary, tangible, intangible, and very, very important here, transportation. Transportation emerged not just for patients, but the technicians, the nurses, and the doctors as well. Communication, a big thing, a big theme that emerged nearly unanimously, I think, on every paper that we reviewed was having a good communication protocol. And we identified some sub-themes under that. The other C is coaching. We stayed away from education because we could see ABCDs of preparedness, but many people, and we're working on it, and we hope to share this data soon, that if patients want coaching, it's not education. It's something that I say today, most people will not remember in 6 months from now. So there's an approach to coaching our patients that if a disaster strikes, this is what should be done. What that approach is, we're still developing, but that's the word we decided to use instead of education. And then the last one, very, very important, strategic partnerships. As I just mentioned, multiple industries, I feel, are involved in delivering care to our patients. And having partnerships with all these people is very, very important to disaster management. In the interest of time, I won't go into details of the response and recovery, but we created a dial response because it's like a phone dial. So you go in circles. And it could be a one-time disaster, or it could be a continuous disaster that requires continuous reassessment. And we talked about the arc to recovery. There was limited literature on how recovery protocols what they should entail, but we did come up with 3 things, and we'll direct everyone's attention to our paper for that.
There's so much to dig into there. Maybe in the interest of time, I'll go on to ask, what do you think are the key lessons that a dialysis director or a staff nephrologist should take away from this study? And a second question, how might those lessons differ in a lower resource setting versus a middle income country, for example?
As I said, roadmap is just an outline. And that can be adapted to a particular context. So the baseline resources in any setting determines our capacity to respond to a disaster. And there are many regions in Canada where there is a deficiency of resources. And when I say resources, I mean personnel and like even roads to get to a particular region. So I do believe that our roadmap can be implemented in any resource setting, because what we say is determine your capacity, and based on that capacity have a contingency plan. So if the capacity at baseline is less, then I think it advises us on how we can implement the roadmap accordingly. Um, what we really hope is that this approach defines kidney programs, individual kidney programs, um, approach to a disaster management protocol, but alongside what others have done. So we're not trying to replace any good work that has been done by the United Nations or by the any of the task forces that were earlier mentioned. But what we're hoping is that we provide sort of an approach to a dialysis director rather than somebody sitting in the ministry. This is what we think you should do, like assess your risks, then build a task force, and then learn what your baseline resources are, or do a quick CQI project on learning your baseline resources and accordingly prepare your protocols. The protocol should not just be tailored to the baseline resources, but the actual risk assessment, something that's a potential for a disaster in a particular region may not be the case for another region. So it has to be adapted to each setting. The last one that I will mention is strategic partnerships. Cross-sectoral partnerships can strengthen capacity throughout the spectrum of disaster management. And this is where I think there's a room for incorporating international emergency management agency, local and state level agencies, as well as big pharmaceutical companies and nonprofit organizations. So maybe that's where, once a particular region has determined this is our risks, there is a more scope for the S of our preparedness, the ABCs, where the strategic partnerships perhaps might be more applicable. Yes, so that's how I would answer this question. Sally, do you have anything to add, perhaps?
Yes, I think maybe to build a bit on that, I think it's for example in a low resource setting, just to reiterate a bit, any plans that would be put in place should first consider the country's financial and logistical capabilities, the geopolitical context, and the environmental circumstances. So, as such, the options that a dialysis director can take or can consider, for example, in Ukraine, would vary a lot in availability and scope than those that a dialysis director would have to think about in Japan or Syria or the US, for example. And even another aspect that would change the availability of these options would be the treatment that is being considered here. So, for example, in some of our ongoing research, our preliminary findings tell us that in home treatments, programs function very differently from in-center dialysis. And so, as such, their disaster management approach should also be different and adjusted to how these programs work. And so, this includes the technical considerations, whereby in this context, patients are primary experts in their own care. They understand how their machines work, their home plumbing systems, and they can troubleshoot their own issues. But this also extends to the medical staff, for example, that needs to be involved in the case of a disaster. For example, in this case, patients would be in contact with the technician or the social worker, whereas in an in-center setting, their nurse could be, or nephrologist could be their main point of contact. And so there are many considerations that need to be thought of when we want to try to operationalize this roadmap that we have.
Thanks so much to you both. Maybe I'll sort of close with one last question for both of you, which is, what do you think are the next steps, either from the research perspective, like what is your group planning to do next, or from a policy perspective?
I almost was like, should I just leave this with like this is upcoming and to be presented soon. But I'll share a couple of things that our group is doing. So the first thing is I think is generating evidence for practices. And there are some great analysis that have come from the US that have looked like, big database analysis linking US RDS data, etc., that looked at mortality. But I think we need even more evidence. We need evidence to guide our practices. So, for instance, when we talk about redirecting care or rationing care means that if we expect a hurricane tomorrow, let's give people dialysis the day prior, then wait when things clear up, and then give dialysis a few days later. Is that approach safe? There's no evidence. So that would be a great, fantastic study to do, where if any center implements this look at the outcomes of your patients, look at their KT over Vs, look at their potassiums, look at, all kinds of other outcomes and train and educate the entire global kidney care community. Was this approach the right thing to do? Or does that approach increases mortality? Ethics. I think we need ethical framework. Something that we noticed in our content analysis is that studies that emerge from resource setting doesn't really talk about, they talk more about like system resource management, whereas studies that are coming from low resource settings talk about rationing care. Like when you have 3 machines and 10 patients, how do you ration care? So I feel somewhere an ethical framework and ethical analysis needs to be done, that how do you try to prioritize and who do you prioritize? And as I mentioned, there's amazing climate science that there are these journals that I've tried to read and understand what they're saying, but it's engineers and like people in the field of geography. So they're pursuing something called climate science, which I learned over the past few years. Climate science is the effort by humans to understand the natural forces that control the climate. And we're working on this like fascinating study with a person that entails GIS analyses and location of dialysis units and wildfire risks. And the whole point being that there is fascinating evidence that requires interdisciplinary approaches to really inform our practice and policy and patient perspective. We did another scoping review where we found quite a bit of lack of patient perspective. Like most of these strategies are informed by, people who are like in charge of organizing these efforts, but at the grounds of people who follow these are not being included in these efforts. So that's some of our ongoing effort. And we really do look forward to sharing those results with the global nephrology community and sort of learning from others as well, where like I'm constantly reading as to what people are doing, and great literature is coming out from other regions and other disciplines. But I think we have to incorporate other sectors as well, because when you read Nature Climate Change or Lancet Planetary Health, it's very interesting what gets published there, and you're like, oh, if I knew that, I would change this in my patients. So somewhere that's where I think the intersectoral collaboration is where I see us going from here, and that's exactly where we're going, and we look forward to sharing those results.
I never thought I would think about the intersection between planetary health and dialysis, but there you have it, an adjacent podcast. Thank you to you both. This has been such an eye-opening conversation. There's clearly a lot of issues that you've raised for myself and our listeners to chew on and to think about how prepared are we and our colleagues for the next disaster. So thank you again. This has just been really such an informative conversation.
Thank you for this opportunity, and thank you for ASN for providing us with this platform to share our work. And, I really appreciate it. And I appreciate the chance to be a part of this podcast series as well.
Great.
Yeah, thank you very much for giving people the chance to know about this important and very impactful work that is going on. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.